Hello, and welcome to Ask Dr. Dawn. The opinions expressed in this program are those of the speakers, and this is a program intended for education and entertainment. It should not be construed as a substitute for a medical consultation. Today's program, we're going to start our rollout by talking about some interesting medical news that came out in the journals this week. Several that I thought were worth talking about for various reasons. Let's start with the one about medical imaging and pediatric and adolescent hematological cancer risk. This just came out in the New England Journal of Medicine last month. It's an interesting study. It's a little alarming. Wish I'd had it for the Halloween show, actually. So let's talk a little bit about X-rays and X-radiation, and then we're going to talk about the study, and then I'm going to comment on the methodology. So starting out just briefly, X-rays are a form of radiation. They come out of the sun. They also are really great for imaging. In the course of a year, we get about 1 milligray, and a gray is the unit of radiation, the internationally agreed upon unit. We get about 1 milligray per year in background radiation. And a chest X-ray is about 0.07 milligrays. So you probably could think of a chest ray as being roughly 8 months worth of background radiation. And we don't think much about giving X-rays. But now let's talk about CT scans and other forms of higher radiation, like film X-rays. We call that fluoroscopy. Angiography, also a form of X-rays. Some of the nuclear medicine studies we use, not X-radiation, but radiation. Just for a reference, when I look at various sources, the estimates for the amount of radiation that you get with a particular study is really quite far off. Not as far off as tenfold, but for example, an internet search gave me on the gray as a unit for radiation, gave me chest X-ray at 0.07 milligray. This study, on the other hand, estimates that for all ages, and this is pediatric and up to the age of 21, it's 0.01, so 1/7 of the dose I just quoted you. Wrist and ankle, these are very, very low. And what this study looked at was an estimate of how much radiation got to active bone marrow. So I think it's very important to realize that maybe the difference is an apples and oranges sort of setup. But let's go with the web for your X-ray is close to 8 months of background radiation. Let's just go with that. Now let's think about this study. They did a retrospective cohort of over 4 million children born between 1996 and 2016 in 6 U.S. healthcare systems and Ontario. So these were from the earliest, these were from 0 years, basically, to 21 years. And they looked at the radiation doses to active bone marrow. The importance of that is that the bone marrow in an adult is active pretty much just in their hips, whereas in a younger person, they have active bone marrow in their sternum, active bone marrow in their head. And so you have an opportunity to, if irradiate, say with a CT scan, there's more bone marrow to be irradiated. And that's important because every bit of radiation represents effectively a lottery ticket in the "Did you mutate my DNA" lottery. Now, we know that in baseline conditions, most of the mutations that occur actually occur randomly, not due to cosmic radiation. But when a person is exposed to high levels of radiation, you can flood the room, if you will, so that the repair mechanisms can, well, basically they can't keep up with the workload and things slip through. I'm remembering that famous I Love Lucy episode with putting the chocolates in the boxes, and the more chocolates were sent out, it became impossible to get them all into the boxes. And so hilarity ensues as they try to figure out how to keep up with the assembly line. Well, that's a little bit like the flooding that occurs when there's a large radiation exposure. Does the system have enough capacity to keep up? In terms of the results, I also want to point out that when you look at 4 million kids, even very small differences become apparent. And this is the law of large numbers in statistics. When you have that many cases, small differences that may not really be all of that clinically meaningful. Obviously, they're meaningful to the individual. But in terms of should we even change our policy globally, it becomes very tricky. And so in these 4 million children over roughly 10 years per person, they had 3,000 hematological cancers. And these included lymphoid cancers like lymphomas, myeloid cancers like multiple myeloma, and leukemias, and also a few stragglers of different subtypes. And when they looked at children, they fell into 2 categories. They either were not exposed to radiation because they didn't get a chest X-ray, they didn't get anything, so those were a 0. There were those who maybe got 1 or 2 chest X-rays, so they would be at a 0.2 millisievert in terms of the radiation that their bone marrow received. And what they saw was a increased relative risk of hematological cancers the more radiation that you got. And what's important here is that the levels of radiation these children were getting are not unusual for when children get a CT. Now, I think there were some methodological flaws, but I'm not going to jump to those yet. It's not really a digression. I'm just going to talk about the fact that there's really an enormous amount of variation in terms of this. How much radiation does your bone marrow get? And by far, the winner of the bone marrow damage sweepstakes is head and brain CTs. Because as I said, there's a lot of bone marrow in the skull, and you're sending the radiation through it to get a look at the brain. So just to give you a sense, the mean dose in under 1 year is 20 milligrays. Remember, that's basically, 100 X-rays. It's 2,000 chest X-rays. So a lot of background radiation, many times the background radiation. When you go from 1 to 5 years, it drops to 17. When you go to 5 to 10 years, it drops to 14. Now, you're still irradiating the head, but the amount of bone marrow that's in there is reduced. And so that's why it changes. When you get to the big kids, which presumably are, 15 to 21 years, you're probably getting close to the adult dosing. And we end up with an estimated dose to the bone marrow of 5 milligrays, which is still enough to confer, according to this study, increased risk of getting leukemia or other lymphoma or other hematological areas, other hematological cancers. This is not the first time someone has looked at this, but this is probably, from a methodologic standpoint, one of the best studies, and the number being very large is going to turn up small differences. There was a lot of estimation going on in terms of a couple of issues. And the first methodological issue here is that they combined 2 cohorts. The U.S. cohort, basically, they had ICD-9 codes because of our insurance system. So they had a good idea of why the radiation was done. And they looked at, well, was this imaging done because the person already had a leukemia or a lymphoma? Because you would, someone comes in with a lump, you might irradiate their head and look for trying to make that diagnosis. And in that case, it can't be causing the cancer. The cancer is causing the imaging. And so how do you decide that? And in the case of the Canadian thing, which was 60% of the examination, so a lot of this work comes from Canada, they just had data from the emergency room or as part of a hospitalization, but they didn't actually have the thing that was being looked for. So that is going to probably overestimate, because it's going to include people who had the scan because they already had cancer. And teasing that out is one of the methodologic flaws in the study. The groups don't match, and so they are just putting people in. They also decided that if a person was diagnosed with cancer more than 6 months after their scan, that represented that the scan caused the cancer. And I would argue that they don't offer a lot of data to support the latency and saying, so there's a lot of chance here that is being attributed to cause and effect. I think that overall, I would, if my child was having a seizure, despite the radiation risk, I would probably want to go looking for a operable brain tumor in my child. So I would buy the lottery ticket of the risk. On the other hand, follow-up examinations, MRIs in children in place of CTs, although CTs are much easier to get a child through. Maybe that's not such a good idea. Although, again, pediatric MRI, I'm not sure that anyone has looked at the long-term side effects of that in children with growth. Children are growing rapidly, and so they tend to be more vulnerable to toxicities. They have a lot more cell division going on in their bodies. So there was a small number of children who probably got had their cancers, and the study included those children, even though it shouldn't have, if you're going to assume causality. Do I think that the study shows that there's a clear connection between getting a head CT and having leukemia or lymphoma later on in your childhood? Yes. I don't think the numbers are necessarily correct, but let's assume for a moment that they are. The risk of getting a CT scan, one CT scan, increases the relative risk by about 1 point, depending on the age, but we're going to take taking all comers, it increases the relative risk by about 1.6. Now, 1.6, that sounds like a lot, 160%. But you have to remember that the incidence of cancer in this cohort was 4 million kids and 3,000 cancers. So from a statistical standpoint, that's a very small increased risk to any given individual who you're multiplying a risk that is extremely low, you still have a number that is extremely low. And the question is the benefit of the procedure commensurate? So are we possibly in some settings doing too many head CTs of children? Should parents be pushing back and saying, is this really justified? Is there any other way we can find this information? Yes. There's a tendency of the way we've set up our medical system to make people very passive. And I think that is something that we all have to resist. I remember when I was strapped to a backboard at over at Natividad after I was in a car accident, I didn't really have a vote about how many times they ran me through the CT scanner. And knowing what I know, I was not particularly happy about the third run through the device that was indicated for who knows what reason. But like I said, that's a kind of, you're strapped to a board, you kind of have, it's hard to refuse treatment. But maybe I should have. I don't know. I still think about that. Anyway, I want you all to feel more empowered and be ready to ask questions and be ready to ask for alternatives. And that's probably the key point. What other strategies or methods do we have to rule out a fractured spine? Not many. Okay. What about a brain tumor? Well, one CT of the brain, no brain tumor. You probably don't need a follow-up CT on that. And maybe that's one of the things we could begin to start chipping away at this admittedly small but very devastating risk. Let's go to our next bit of news. And this was a cutting-edge therapy. I want to add that it is funded by industry and it's not published. It was presented last week at a meeting of the American Heart Association and is going to be published. And I don't know if it's even gone through peer review yet. The blurb I'm reading does not say that. But it is using CRISPR technology to take out a gene that is responsible for a enzyme that is involved in the production of and management of low-density lipoprotein, which is bad cholesterol, and triglycerides. So they used a lipid nanoparticle, which is basically a fat bubble, to deliver messenger RNA, just like your COVID vaccine, or most of us who got the mRNA vaccine. It basically creates a targeted molecular scissors that snips the PTL3 gene. So because the CRISPR is essentially a bit like a targeting program, when you find that right sequence, you know you're in the right place, so you can act on the gene that follows that sequence. And that's what they do. So this has been around since 2013. It was originally reported. We were all very excited about it back then. And we're starting to see the implications of CRISPR. You discover something and then you have to figure out how to use it. Well, they're figuring out how to use it. And should this CRISPR therapeutics study and the company that sponsored it be successful, this could be a real game changer for people who have high levels of cholesterol that refuse to respond to therapy. Now, that being said, CRISPR therapies had some recent real setbacks. Just recently, a patient died in a different gene editing trial. There were two editing trials from Intellia Therapeutics that the regulators put on hold last month. And this was, they were treating a rare disease that causes heart failure. And the patient actually developed severe liver toxicity. And this liver toxicity concept is starting to raise a little bit of worrisome. Verve Therapeutics in 2023 showed that they could reduce LDL with a therapy that edited a gene called PSCK9, which is a receptor for cholesterol on the liver surface. It picks it up from the blood. After enrollment, one patient developed low platelets and evidence of liver damage, so they paused their study. They thought that maybe the lipid nanoparticle, they speculated, might have been the problem, and they are now coming back at the study using a different lipid nanoparticle. It's not clear whether the person who developed who died last week from heart failure, from liver toxicity, we're not entirely sure that this killed them. The condition they have can also cause damage to the liver. But here's one that really worries me, not this sort of drug development stuff, because this is what happens when you're starting from scratch and trying to develop drugs. The real concern is, what about either off-target effects, in other words, the CRISPR doing something to a gene that isn't the target, and that has been, I think, largely solved, but still potential for that. But what if the edited cells were not fully edited? What if you missed some of them? Or what if you damaged the DNA, but it gets partially repaired so that you could make a mutated version of a protein? Should that occur, that could trigger a harmful immune reaction, possibly a lethal one, certainly an autoimmune condition. So, yeah, it's great technology, and I'm very excited about it, but we have to proceed with caution, and I think we need to pick our targets. Going after cholesterol is certainly a big market, but from my standpoint, I think only those with genetic disease should be eligible for genetic therapy. And we have to be very selective about that because we're still learning. So life-threatening disease, no other alternative treatment, nothing that can be done. All right, well, maybe you try it, but we need a very high threshold for saying you're not sick enough on this one. So there's a debate going on this week about a tech breakthrough that is, well, it's got the scientific community all aflutter. A group of Stanford University scientists posted a paper about a month ago describing a feat that sounds like science fiction. They used artificial intelligence to design new viruses capable of killing bacteria. Well, not quite. It's not the same as AI writing poems in the style of Emily Dickinson or making friends with lonely teenagers. Depending on your belief system, what AI was doing there was evolution. And maybe we want to think twice before we give it the tools to work on bacteria or especially eukaryotes. The paper has not been peer-reviewed. It was posted, but it's really spawned a lot of consternation. What did they do? They used Evo, which is a generative AI model trained on the genomes of living things. And just like other large language models are trained on massive amounts of data from the internet and text, the most advanced version of Evo ingested about 9 trillion letters of DNA from an atlas spanning all domains of life. That might be just a little bit too much discovery, but this is a relatively primitive device, so I'm not too worried yet. But AI tools have really helped us. We need to be careful what we ask the genie to do, but putting the genie back in the bottle is just too big a temptation. AI tools now allow us to predict the structure of proteins and build new ones. We can design a drug to fit into a receptor, even a broken receptor. We can turn off the production of the broken receptor. We're already using the tools to devise new antivenom therapies for snake bites, inventing new antibiotics, improving vaccines, and, this one I love, breaking down PFAs, the so-called forever chemicals. We can design compounds that will do that, even though none exist in nature. Now, what we do with the byproducts, again, better think that one through before you release it. But it does open up new risks, particularly in respect to, well, creating toxins. In this paper, what did they do? They built the entire genome for a very simple type of virus called a phage. A phage is a lethal parasite that infects bacteria. And they took this phage PHI-X174, which happens to be the very first phage that was ever sequenced almost 100 years ago. Now, amazing, huh? Took us a while, but we got there. And then the way this phage works is it injects its genome into E. coli, and it takes over the cellular machinery and to make more and more copies of itself, and then that eventually explodes the cell, and out go all of the other phages to go look for more targets. So they synthesized about 300 different phages, starting from scratch, using the Phi X174 as a model, if you will, for the structure. And then they found, when they tested it, that about 16 of them were functional. That is to say, they killed the bacteria. We've been working on phages to kill bacteria for a while. I covered this at least sometime briefly in the last 6 months. And phages are very, very small and short, about 5,000 letters long, as opposed to maybe 30,000 letters long for a bacteria. Now, this wasn't just a solo act on the part. The expert team fine-tuned the model, devised design constraints, and prompted the program to propose new DNA sequences. But when it did that, they had it synthesized, assembled, and put it in the test tube with the E. coli, and they found that 16 of them were, in fact, active at killing viruses. The viruses were active at killing bacteria. Is it imitating what we've told it? Sure. But that's what all knowledge is. I think it's a first step. It's a first step on a path that needs guardrails, and that is what we seem to be struggling with in AI, is how do we constrain our desire to move quickly and break things when the things we break may be the very structure of our biology. Well, I guess we'll get a chance to see if we all win the Darwin Award. So I'm going to tell you now about, this came from an email from Moose, a longtime listener. Thanks, Moose. I finally got around to responding to your email. But it fits so well with this sort of rampant capitalism versus thoughtful approaches. This is a story. So we'll start with that. In 1991, Harris Rosen had an epiphany. He had expected his insurance company's renewal would be significantly lower than the previous year based on more favorable claims experience. But to his surprise, the quote was higher. Now, it was part of a fully insured group, and unfortunately, that fully insured group hadn't performed well. So even though his segment had his small business or smallish business, it hadn't paid off, because in insurance, you spread the risk and you make sure you buffer in some profit. So Mr. Rosen, who said, we're going to switch to a self-insured group health plan. But he went much further than most CEOs. He went out of his way to ensure better access to quality care. Coverage at this hotel chain now features direct contracting with medical providers, an imaging facility where MRIs and CT scans are one-third to one-half the cost of those in traditional insurance, a transparent pharmacy benefit manager. In other words, you know how much they pay for the drug, and you know the markup. Sort of like Cost Plus, Mark Cuban Cost Plus, which I want to give a shout out to what I consider to be a very fair and rational approach to drug prices. Buy them in bulk, get your lowest possible price, slap on a markup that supports the company and makes it a reasonable profit, and let people buy directly, eliminating about 3 levels of middleman, including the pharmacy. So, it's amazing how many people are taking a cut. It almost reminds me of the illegal drug trade for heroin in terms of how many people on that pathway are taking a cut. So the company, the RosenCare model, has earned national recognition as a patient-centered on-site medical home. And they've expanded. They've rolled out to a dozen other employers across Florida using the same strategy. So simple stuff. They visit the employees and family members are screened for their needs before they visit the clinic, and they can get their lab work done. But they'll also be checked for whether they're due for a colonoscopy, a mammogram, or a cholesterol check. And they screen them for diabetes and hypertension. Both of these are easy to screen for if you take literally 1 minute. And if you catch people when they first develop these conditions, it makes an enormous difference to the cost of treating them. As much as 75 to 85% of an employee's health care is spent on chronic care conditions. So why not find those early and treat them effectively? Just another words about this healthcare haven: employees don't pay a deductible or coinsurance. Copays for the primary care visits are either $0 or $5. 90% of the medicines, including insulin, are available at no cost, and out-of-pocket costs for the remainder of prescription drugs range from $0 to $25. Now, I ask myself, how are they managing to do the biologicals in this setting and keep the price that low? They do charge $750 for any hospital admission, regardless of whether it's for a heart transplant or a premature baby. So Mr. Rosen has passed away, but what he built continues to inspire others. And they've also taken about $600 million in savings, money they would have spent on standard insurance and eventually finding its way to Wall Street as dividends and private equity fund money. Instead, it goes, that may have been naive. I really don't understand private equity, so let me clarify that. But still, it's nice to have a story of how it could be done if we simply thought outside the box. And as a parenthetical comment, most people are having trouble in our community finding a primary care doctor who will take new patients. That's just not a sustainable thing. What can we do? Well, we can make more primary care doctors. That'll take about 8 years, and you'll have to change the pay scale to attract people into that pathway. You can make more paraprofessionals like nurse practitioners and physician's assistants who are wonderful and very competent, but who are really good at ordinary stuff and not really good at rare stuff because they don't spend the extra 6 years learning that. So with total hats off and no complaints about any physician assistant or nurse practitioner I've ever worked with, the truth is it really is nice to have that little extra knowledge about the obscure stuff because early diagnosis is important. So here's something that you may find interesting. A common cause of bloating that you've never heard of that has nothing to do with food and it has nothing to do with gas. It's called abdominophrenic dyssynergia. It may be the blame for many people who bloat after meals. Most people think it's just intestinal gas pushing their bellies outward. They start changing their diets, not eating. I've gotten advice, don't eat garbanzo beans, don't eat beans at all. Don't eat, broccoli. But these are actually very healthy foods, and I'm not willing to give them up. And often it doesn't seem to make a difference. But for many people, frequent bloating is not gas or backed up stool. It's an abnormal muscle response, something that gastroenterologists largely don't understand. So let's step back and think about the abdominal cavity. This is essentially like a suitcase, and it's lined with peritoneum, and it contains all the internal organs that you think of when you think of the abdomen: liver, stomach, and it's like a cardboard box in the metaphor here. Sometimes the issue with the collapse of the box or the pooching out of the box may not be what's inside the box, but whether it's the box itself. So for many people during their bloating episodes, the diaphragm, which is the muscle that separates the lungs from the abdomen, drops, and the abdominal muscle walls relax. This is a reflex, and so it pushes everything within the abdominal cavity, including the bowels, forward. And so this is a bloating that often occurs right after meals, and people tried changing their diets, sometimes using betaine hydrochloride or hydrochloric acid or apple cider vinegar will help with that. I don't know why, but it's a fairly common problem. So it's not gas. Now, many people, and like I said, maybe apple cider vinegar is good because it somehow prevents the diaphragm from descending through a reflex. That's certainly possible. Many people say that lettuce gives them gas and bloating, but a study done in 2019 found that our gut microbiomes do not ferment lettuce. So it's not just gas from fermentation. It's not some lettuce version of SIBO. And CT scans of the abdomen revealed that people who complain of bloating after eating lettuce have no significant changes in the amount of intestinal gas compared to before eating. Instead, what those scans showed is a descending diaphragm and a protruding abdominal wall muscles that force their bowels from resting comfortably under the rib cage to moving closer to the belly button, which is going to put all kinds of things on stretch. So obviously, not everybody has this problem, but people who have played around with stopping lactose and stopping beans and following all of the standard advice and like a trial of a FODMAP diet and still have problems, well, then maybe it's sluggish bowels and you need medicine. Maybe it's this. And how do we treat this syndrome of, I'm going to have to look up the name, it's such a crazy name, abdominal phrenic dyssynergia. How do we treat it? Well, biofeedback training and posture. 2 randomly controlled studies showed that certain kinds of physical therapy, exercise using biofeedback, can train patients to mobilize their diaphragm and reduce bloating. So that these measures involved lifting the chest and contracting the abdominal wall. Well, it sounds like good posture. But people who did these exercises before and after eating for 4 weeks experienced a 66% symptom improvement. So let's contract the abdominal wall and lift the chest and breathe out. All right. Now, when you breathed out, you just lifted your diaphragm. Now, rather than letting your diaphragm drop, hold it and take shallow chest breaths and practice this. And do a little bit of this before and after your meals and see if you notice a difference. You have nothing to lose but your bloat. Oh, one last thing. When a post-menopausal woman comes to me complaining of bloating, and the bloating is all the time, even first thing in the morning when she hasn't had anything to eat, you've got to check for ovarian cancer. You've got to go and look under that particular rock, because this is one of those cancers that is often not found, like pancreatic cancer, which we talked about a bit last week. It's not found until it's quite advanced. The bloating is an example of something that can occur quite early. And so, wow, we really want to check that out. Not everybody with bloating is going to have ovarian cancer. Don't get freaked out. But certainly, if it doesn't change with eating and it's happening without a lot of farting or burping, you have to think about maybe getting investigated for other causes. Let's go to something interesting I find about those little genetic variations that we've sort of alluded to. Well, dopamine receptor is the dopamine receptor 4 is encoded by the gene DRD4, and it has a lot of polymorphisms. So that means that there's a little change somewhere along the DNA, usually even one base pair, and the DR4 gene does something really unusual. near the telomere of of chromosome 11p, it exhibits what they call an unusually high amount of expressed polymorphism. So this contains a 48 base pair that gets repeated over and over again between 2 and 11 times. This repeat has a profound effect on human personalities. It causes the gene to stretch and twist, and how many repeats you have is, well, among other things, genetically determined. The 7 repeat is really rare in Asia at 2%, but 48% of Americans have it. And this 7 repeat has creates a receptor that doesn't attach to dopamine as well. So it's associated with a lot of psychiatric disorders and remember, this is when you have someone who has a disease, so you go looking for the gene. And what they find is that it's associated statistically with drug dependencies, ADHD, pathological gambling, alcoholism, drug dependence, and bulimia. And these are also all things that we know the dopamine loop has a lot to do with. There's also some soft associations with schizophrenia. The polymorphism has also been characterized with just a certain kind of personality, a person who's a novelty seeker, maybe a little bit impulsive, maybe a little more thrill-seeking and aggressive than other types. Another thing that you see in a different variation is that's the 2 repeat allele, and that's the one that's common. That's more common in Asia. In the 2 repeat, you find a significant lower anger and tendency to anger and higher forgiveness rates. So personality traits have both biological and evolutionary backgrounds. They're biological, but they're also cultural, and how the culture shapes them turns out to be responsible for a lot of what happens. So the 7 repeat is the novelty seeking and risk taking. They're less sensitive to dopamine, so they need more, but they tend to be more optimistic, and they're more reward driven, which I thought was interesting. The DR2 receptor has some variations as well. I thought this was really interesting. If you have the DRD2, you have essentially enhanced learning and memory of negative outcomes. So you remember when things went bad literally more clearly and for longer than when things went well. This creates a pessimistic bias in the person and also avoidance-based behavior. Who would have thought that we could identify at least trends or tendencies in how a person interacts with the world that's based on something so simple as the shape of a receptor in their brain? I at least find that super interesting. We've got enough time to talk about the Keto trial, which I'm particularly interested in. Cholesterol just got a lot more complicated. Physiologic phenotypes are turning out to be really interesting. And what a physiologic phenotype means is not what your DNA there on the chromosome is doing. It's what genes are active. So, for example, red hair and blue eyes are a human phenotype. The child phenotype it's pretty hard to tell unless they're dressed differently what sex they are. But at puberty, you get emergence of a much more obvious male and female phenotypic shift: height, weight, muscle distribution, etc. Obviously, the genitalia are different, but with pants on, you really can't necessarily tell the difference until puberty. In people who have very carbohydrate restricted ketogenic diets, you can get very high levels of LDL-C, which would normally be thought of a risk factor, as a risk factor for heart disease. But if you have a low triglyceride, high density lipoprotein cholesterol ratio, you can get this lean mass hyper-responsive responser phenotype. Now, these are people who may have an LDL-C of 190, a high-density cholesterol greater than 60, and triglyceride levels lower than 80, and they don't have any familial disease. They're just eating very, very low carbohydrate diets. And you would think that if you were to do like CT angiography or coronary calcium studies, that you would find more coronary artery plaque in someone with an LDL of 190. But this study looked at a mean, these were 55-year-olds on the average. They had an average LDL of 272. Now that blows my brain. That blows my brain out at the top of my skull. No matter how statin skeptical I am, I would have a hard time not treating that with standard cholesterol lowering drugs. And they had been on this keto diet, very strict one, for 5 years. What they found was that they, compared to a control group, there was absolutely no difference between their coronary artery calcium score, their total plaque score, and essentially no difference at all. And there was no correlation whatsoever between coronary plaque and high LDL-C. This was, by the way, the matched cohort had an LDL of under 150. So it's really quite astonishing. And this has, I think, the very, very low carbohydrate diet over time induces a physiologic phenotype that is actually neutral in terms of cardiovascular risk, despite having very, very high levels of LDL. So I think you have to see the high LDL as being biphasic, particularly depending on the amount of carbohydrate being consumed by the individual. Why does the body make this change? Well, keto diets are very high in fat, and presumably the fat has to go somewhere, but for some reason, and it may just be that these people will have, because of their diet, very low insulin levels, that very low insulin level is protective against the development of coronary artery disease, because even though you have a lot of LDL, the LDL does not become oxidized. It doesn't become charged. And that charging, I call it loading of the gun. An LDL by itself, even a small LDL particle, if there's no inflammation or low inflammation, then it can't fire because it's not loaded. And maybe that is the unified field theory of cholesterol in a nutshell. I'm going to take a moment to give you a quick one. I thought I came across this one I thought was very, very good, and it was just a very surprising symptom of cancer that is related to alcohol. So I'm going to read this letter. It's written by columnist Mikhail Sakaris, MD. He's an oncologist. And he says, I cared for a patient years ago who told me she had chest pain that lasted a day or two every time she drank a glass of wine. A CT of her chest uncovered a large mass in her lungs, and sure enough, a biopsy confirmed that it was a Hodgkin's lymphoma. Many people experience pain or irritation after drinking alcohol in the lower chest or abdomen due to inflammation of the esophagus or stomach. This is esophagitis or gastritis, and it's relieved by antacids or proton pump inhibitors. But a pain in a discrete area of the body occurring consistently following alcohol ingestions, such as in a lymph node or in the lower back, may be a sign of cancer. In one study, this phenomenon was found in at least 5% of people who were diagnosed with Hodgkin lymphoma. What's going on here? Well, the pain is hypothesized to be due to dilation of blood vessels, a normal effect of alcohol, happening in a lymph node that is already containing metastatic cancer, or cancer in the case of Hodgkin's lymphoma, and triggering the release of inflammatory chemicals. I would say both of those, because if the pain lasts for a day, there has to be a chemical component beyond just the vascular effect of alcohol. So something to keep in mind, recurrent pain after drinking alcohol, always lasting a while and in the same place. You might want to see your doctor and ask for maybe some scanning and some evaluation. That would not be true if it's in your upper stomach or esophagus. You just need to stop drinking. All right. Looks like we've come to the end of the hour. Well, that's about all for this week's podcast. Please go to AskDrDawn.com for news about our future plans. For now, this is Dr. Dawn saying so long and stay healthy.
Ask Dr. Dawn is brought to you by Jiva Media. Production and editing by Charles Bansky. Music by John Scoville.